Hi, I am Dr. Ulka Vaishampayan. I'm Chief of Solid Tumor Oncology at Karmanos Cancer Center and Professor of Oncology at Wayne State University in Detroit, Michigan. Today we're going to talk about how patient risk stratification can drive treatment selection in advanced RCC. Before we get into a patient case, I will review some of the important safety information for Votrient. Votrient pazopanib tablets is indicated for the treatment of patients with advanced renal cell carcinoma. Important safety information for Votrient. There is a boxed warning for Votrient hepatotoxicity. Severe and fatal hepatotoxicity has been observed in clinical trials. Monitor hepatic function and interrupt, reduce, or discontinue dosing as recommended. I will review additional important safety information further along in this presentation. When deciding on treatment for advanced RCC, tailoring the treatment to the patient characteristics for a personalized strategy becomes important. The different characteristics you would consider are patient and tumor-related characteristics, as well as patient risk factors. Numerous variables, such as the clinical performance status, the lab values, are all evaluated before a treatment plan is formulated for an advanced RCC patient. Here we have a case of Vincent, who is a 66-year-old man with advanced RCC. His initial presentation was with hematuria, but no other clinical symptoms. His CT scan showed a large left kidney mass. His performance status is excellent at 0. He previously had a surgical history of gallbladder removal, but otherwise on physical exam, his abdominal exam was completely normal, and the rest of his findings were basically normal. Okay, so the patient now had radical nephrectomy with lymph node dissection for the kidney mass. And the tumor was a clear cell kidney cancer, which was, Fuhrman nuclear grade 3, which is relatively aggressive. All the lymph nodes were negative, and the tumor appeared to be organ confined at the time of the surgery. So the patient, as he was being put on surveillance, every 3 months, CAT scans were done, and those were within normal limits. The patient continued to be asymptomatic and recovered from the surgery. So how do you evaluate or approach the assessment of patients when they find distant metastases, which is what happened to this patient? He had lung masses detected on a CAT scan 18 months after surgery. The patient was still asymptomatic. This was found on a routine surveillance CAT scan. And the question is, what factors should you consider as you evaluate a treatment approach for this patient? When considering favorable risk patients for treatment with Votrient, you have to keep in mind that the risk criteria have evolved over time. When the Votrient pivotal trial was conducted, the MSKCC 1999 criteria were used, and these are different from the IMDC 2009 criteria. For instance, in the IMDC 2009 criteria, if a patient's disease became metastatic less than a year after the initial diagnosis, this is considered an intermediate risk patient. However, in the MSKCC criteria, that would have been a favorable risk patient. When looking at the Votrient phase 3 pivotal trial, patient baseline characteristics are important to note. The vast majority of the patients had favorable or intermediate MSKCC risk status, as shown in the pie charts. Patients were either ECOG performance status 0 or 1. Age ranged from 25 to 85 years, and the median age was 59 years. Approximately 50% of all patients had 3 or more organs involved with metastatic disease. The most common metastatic site at baseline was lung, followed by lymph nodes, bone, and liver. About half of the patients were frontline or treatment naive, and the other half were pre-treated with cytokine-based therapy, in which the majority had received interferon-based treatment. Similar proportions of patients in each arm had prior nephrectomy, and all patients had clear cell histology or predominantly clear cell histology. So going back to our case study of radical nephrectomy followed by a presentation of metastatic disease, this patient has favorable risk because he presented 18 months after surgery with lung metastases. So, what are the goals of therapy in the frontline setting? We just discussed the patient baseline characteristics in the Votrient pivotal trial. Now let's take a moment to refresh on the study design. The safety and efficacy of Votrient in advanced RCC was evaluated in a randomized, double-blind, placebo-controlled, multi-center phase 3 trial. 435 patients were randomized in a 2:1 fashion to either receive Votrient 800 mg orally daily or placebo once a day. The table on the left shows efficacy data from the phase 3 trial for the overall population, which was a mixture of treatment-naive and cytokine pretreated patients. Significantly prolonged progression-free survival was seen in the patients with advanced RCC receiving Votrient, which were 290 patients, compared with those receiving placebo, 145 patients. The median PFS was 9.2 months for Votrient versus 4.2 months for placebo. Significantly prolonged PFS was demonstrated in patients on first-line therapy with Votrient. The median PFS was 11.1 months for Votrient versus 2.8 months for placebo, which corresponds to an extension of the median progression-free survival by more than 8 months. In cytokine pretreated patients, the median PFS was 7.4 months for Votrient versus 4.2 months for placebo. A higher response rate was also observed in patients on frontline therapy with Votrient, which response rate was 32% versus placebo, it was 4%. In cytokine pretreated patients, response rate was 29% in the patients receiving Votrient versus 3% in the patients getting placebo. In the case study that we're discussing of Vincent, the patient with ECOG performance status 0 and favorable risk, let's take a look at the data for Votrient tablets that are specific to such cases. Subgroup analysis of PFS data from the phase 3 trial showed a reduced risk of progression with Votrient versus placebo in patients with ECOG performance status 0, which is 183 patients, and those with favorable MSKCC risk status, 170 patients. Median PFS was 14.8 months for Votrient in both subgroups of patients, as compared to placebo. Median PFS was 4.2 months in patients with ECOG performance status 0 and 5.6 months in patients with favorable MSKCC risk status. Additionally, for patients such as Vincent with ECOG performance 0 and or favorable MSKCC risk status, data for Votrient show that median overall survival was more than 2.5 years for patients like him who received Votrient. In patients with ECOG performance status 0, median overall survival was 32.1 months for Votrient versus 29.6 months for placebo. In patients with favorable MSKCC risk status, median OS was 35.9 months for Votrient versus 34.1 months for placebo. Although not applicable to this patient case, please note that in the pivotal phase 3 trial, ECOG performance status 1 and intermediate MSKCC risk patients also experienced benefit from treatment with Votrient. Median PFS in patients with ECOG performance status 1 was 7.4 months for Votrient versus 2.8 months for placebo. In intermediate MSKCC risk patients, median PFS was 5.6 months for Votrient versus 2.8 months for placebo. Median OS in patients with ECOG performance status 1 was 19.1 months for Votrient versus 18.3 months for placebo. In intermediate MSKCC risk patients, median OS was 19.4 months for Votrient versus 13.5 months for placebo. Here are the CT scans that show the lung masses detected at baseline. Vincent had favorable risk status and was asymptomatic and was initiated on Votrient 800 mg daily for first-line treatment of stage 4 clear cell RCC. During a follow-up visit at 3 months, the CT scan showed shrinkage of the lung masses compared with their size at baseline. Vincent experienced some grade 1 diarrhea. A dose adjustment was not required. Now let's think about the management strategies you would use to address adverse reactions from Votrient. This table shows the most common adverse reactions that occurred in patients who received Votrient in the phase 3 pivotal trial. The most common adverse reactions with Votrient tend to be diarrhea, hypertension, hair color changes, nausea, anorexia, and vomiting. Within that, the severe adverse reactions are predominantly diarrhea and hypertension. Severe and fatal hepatotoxicity has been observed in clinical trials. Monitor hepatic function and interrupt, reduce, or discontinue dosing as recommended. The incidence of grade 3 or 4 adverse reactions with Votrient in the phase 3 trial was low. This graph shows the incidence of grade 3 or 4 and all grade toxicities, namely fatigue, asthenia, hand-foot syndrome, stomatitis, and mucositis. In patients taking Votrient, the rate of grade 3 or 4 adverse reactions was about 4% or less. Discontinuation rate in the overall population was 15% in the Votrient arm versus 6% in the placebo arm. In patients on frontline therapy, the discontinuation rate was 12% with Votrient as compared to 6% with placebo. Among cytokine pretreated patients, the discontinuation rate was 19% with Votrient versus 4% with placebo. Now let's take a look at this table showing the most common lab abnormalities with Votrient. The most common grade 3 or 4 toxicities are AST and ALT elevation. The other grade 3 or 4 toxicity incidence is fairly low. The recommended starting dose of Votrient is 800 mg orally once a day. Votrient must be taken without food at least 1 hour prior or 2 hours after a meal. If a dose is missed, it should not be taken if it is less than 12 hours until the next dose. Do not crush the tablets due to the potential for increased rate of absorption, which may affect systemic exposure. Initial dose reduction should be to 400 mg, and additional dose increase or decrease should be in 200 mg steps based on individual tolerability. Modifications may be required in patients with pre-existing hepatic impairment. No dose adjustment is required in patients with mild hepatic impairment. In patients with moderate hepatic impairment, alternatives to Votrient should be considered. If Votrient is used in patients with moderate hepatic impairment, the dose should be reduced to 200 mg per day. Votrient is not recommended in patients with severe hepatic impairment. In the case study that we're discussing of Vincent, these CT scans show that at 6 months after initiation of Votrient, significant reduction occurred in the size of the lung masses compared with the size at baseline. At 10 months, there was no evidence of disease progression, and Vincent remains on 800 mg per day dose of Votrient. To summarize, Votrient is an established treatment with clinical and real-world experience in advanced RCC. Votrient has more than 8 years of clinical experience. Over 4,000 patients with advanced RCC have been treated with Votrient in clinical trials and real-world studies. This includes 1,350 patients from clinical trials and 2,850 patients from real-world studies. Votrient is the #1 prescribed oral therapy for frontline treatment of patients with advanced RCC. Now let's review the additional important safety information for Votrient. Votrient pazopanib tablets is indicated for the treatment of patients with advanced renal cell carcinoma. Important safety information for Votrient. There is a boxed warning for Votrient hepatotoxicity. Severe and fatal hepatotoxicity has been observed in clinical trials. Monitor hepatic function and interrupt, reduce, or discontinue dosing as recommended. Hepatic toxicity and hepatic impairment. Severe and fatal hepatotoxicity has occurred. Patients older than 65 years are at an increased risk. Increases in serum transaminase levels, ALT or AST, and bilirubin were observed. Transaminase elevations occur early in the course of treatment. 92.5% of all transaminase elevations of any grade occurred in the first 18 weeks. In patients with pre-existing moderate hepatic impairment, the starting dose of Votrient or pazopanib tablets should be reduced to 200 mg per day, or alternatives to Votrient should be considered. Treatment with Votrient is not recommended in patients with severe hepatic impairment. Concomitant use of Votrient and simvastatin increases the risk of ALT elevations and should be undertaken with caution. See drug interactions. Before the initiation of treatment and regularly during treatment, monitor hepatic function and interrupt, reduce, or discontinue dosing as recommended. QT prolongation and Torsades de Pointes. Prolonged QT intervals and arrhythmias, including Torsades de Pointes, have occurred. Use with caution in patients with a history of QT interval prolongation, patients taking antiarrhythmics or other medications that may prolong QT interval, and those with relevant pre-existing cardiac disease. Baseline and periodic monitoring of electrocardiograms and maintenance of electrolytes, example calcium, magnesium, potassium, within the normal range should be performed. Cardiac dysfunction. Cardiac dysfunction such as congestive heart failure and decreased left ventricular ejection fraction has occurred. In the overall safety population for RCC, cardiac dysfunction was observed in 0.6% of patients without routine on-study LVEF monitoring. In a randomized RCC trial of Votrient compared with sunitinib, in patients who had baseline and follow-up left ventricular ejection fraction measurements, myocardial dysfunction occurred in 13% of patients on Votrient compared with 11% of patients on sunitinib. CHF occurred in 0.5% of patients on each arm. Monitor blood pressure and manage promptly using a combination of antihypertensive therapy and dose modification of Votrient, interruption and reinitiation at a reduced dose based on clinical judgment. Carefully monitor patients for clinical signs or symptoms of CHF. Baseline and periodic evaluation of LVEF is recommended in patients at risk of cardiac dysfunction, including previous anthracycline exposure. Hemorrhagic events. Fatal hemorrhagic events were reported in 0.9% of patients in the RCC trials. In the randomized RCC trial, 13% of patients treated with Votrient compared to 5% of patients on placebo experienced at least one hemorrhagic event. The most common hemorrhagic events were hematuria in 4%, epistaxis in 2%, hemoptysis in 2%, and rectal hemorrhage in 1%. Votrient should not be used in patients who have a history of hemoptysis, cerebral or clinically significant gastrointestinal hemorrhage in the past 6 months. Arterial thromboembolic events. Arterial thromboembolic events have been observed. including fatal events in the RCC trials. In the randomized RCC trial, 2% of patients receiving Votrient experienced myocardial infarction or ischemia, 0.3% had a cerebrovascular accident, and 1% had an event of transient ischemic attack. No arterial thromboembolic events were reported in patients who received placebo. Use with caution in patients who are at increased risk for these events or have a history of these events. Do not use Votrient in patients who have had an arterial thromboembolic event in the past 6 months. Venous thromboembolic events, VTEs have occurred, including venous thrombosis and fatal pulmonary emboli. In the randomized RCC trial, VTEs were reported in 1% of the patients treated with Votrient and in 1% of the patients treated with placebo. Monitor for signs and symptoms. Thrombotic microangiopathy, TMA. TMA, including thrombotic thrombocytopenic purpura or TTP and hemolytic uremic syndrome or HUS, has been reported in clinical trials of Votrient as monotherapy, in combination with bevacizumab, and in combination with topotecan. Votrient is not indicated for use in combination with other agents. 6 of the 7 TMA cases occurred within 90 days of the initiation of Votrient. Improvement of TMA was observed after treatment was discontinued. Monitor for signs and symptoms of TMA. Permanently discontinue Votrient in patients developing TMA. Manage as clinically indicated. GI perforation and fistula. In RCC trials, GI perforation or fistula was reported in 0.9% of patients receiving Votrient. Fatal perforation events occurred in 0.3% of these patients. Use with caution in patients at risk for these events and monitor for signs and symptoms. Interstitial lung disease, ILD, or pneumonitis. ILD or pneumonitis, which can be fatal, has been reported in 0.1% of patients in the clinical trials treated with Votrient. Monitor patients for ILD or pneumonitis and discontinue Votrient if symptoms of ILD or pneumonitis develop. Reversible posterior leukoencephalopathy syndrome or RPLS. RPLS has been reported and may be fatal. Permanently discontinue Votrient in patients developing RPLS. Hypertension. Hypertension, including hypertensive crisis, has occurred in clinical trials. Hypertension occurs early in the course of treatment. Approximately 40% of cases occurred by day 9, and 90% of cases occurred in the first 18 weeks. Blood pressure should be well controlled prior to initiating Votrient, monitored early after starting treatment, no longer than 1 week, and frequently thereafter. Treat increased BP promptly with standard antihypertensive therapy and dose reduction or interruption of Votrient as clinically warranted. Discontinue Votrient if there is evidence of hypertensive crisis or if hypertension is severe and persistent despite antihypertensive therapy and dose reduction of Votrient. Approximately 1% of the patients required permanent discontinuation of Votrient because of hypertension. Wound healing. Votrient may impair wound healing. Interruption of therapy is recommended in patients undergoing surgical procedures. Treatment with Votrient should be stopped at least 7 days prior to scheduled surgery. Votrient should be discontinued in patients with wound dehiscence. Hypothyroidism. Hypothyroidism was reported in 7% of patients treated with Votrient in the randomized RCC trial and in no patients receiving placebo. Monitoring of thyroid function tests is recommended. Proteinuria. In the randomized RCC trial, proteinuria was reported as an adverse reaction in 9% of patients receiving Votrient, leading to discontinuation of treatment in 2 patients. There were no reports of proteinuria in patients receiving placebo. Monitor urine protein at baseline and periodically as clinically indicated. Interrupt treatment for 24-hour urine protein of 3 grams or higher and discontinue for repeat episodes despite dose reductions. Infection. Serious infections with or without neutropenia, some with fatal outcomes, have been reported. Monitor for signs and symptoms and treat active infection promptly. Consider interruption or discontinuation of Votrient. Increased toxicity with other cancer therapy. Votrient is not indicated for use in combination with other agents. Increased toxicity and mortality have been observed in clinical trials administering Votrient in combination with lapatinib or with pemetrexed. The fatal toxicities observed included pulmonary hemorrhage, GI hemorrhage, and sudden death. A safe and effective combination dose has not been established with these regimens. Increased toxicity in developing organs. The safety and effectiveness of Votrient in pediatric patients have not been established. Votrient is not indicated for use in pediatric patients. Animal studies have demonstrated pazopanib can severely affect organ growth and maturation during early postnatal development and resulted in toxicity to the lungs, liver, heart, and kidney, and in death. Votrient may potentially cause serious adverse effects on organ development in pediatric patients, particularly in patients younger than 2 years of age. Females and males of reproductive potential. Votrient can cause fetal harm when administered to a pregnant woman based on animal reproduction studies and its mechanism of action. In animal developmental and reproductive toxicology studies, oral administration of pazopanib to pregnant rats and rabbits throughout organogenesis resulted in teratogenicity and abortion at systemic exposures lower than that observed at the maximum recommended human dose of 800 milligram. Verify pregnancy status of females of reproductive potential prior to starting treatment with Votrient. Advise females of reproductive potential to use effective contraception during treatment and for at least 2 weeks after the last dose of Votrient. To avoid potential drug exposure to pregnant partners and female partners of reproductive potential, advise male patients, including those who have had vasectomies, with female partners of reproductive potential to use condoms during treatment with Votrient and for at least 2 weeks after the last dose. Votrient may impair fertility in females and males of reproductive potential while receiving treatment. Because of the potential for serious adverse reactions in breastfed infants from Votrient, advise a lactating woman not to breastfeed during treatment with Votrient and for 2 weeks after the final dose. Diarrhea. Diarrhea occurred frequently and was predominantly mild to moderate in severity. Patients should be advised how to manage mild diarrhea and to notify their healthcare provider if moderate to severe diarrhea occurs, so appropriate management can be implemented to minimize its impact. Lipase elevations. In a single-arm RCC trial, increases in lipase values were observed for 27% of the patients. In the RCC trials of Votrient, clinical pancreatitis was observed in less than 1% of the patients. Pneumothorax. 2 of 290 patients treated with Votrient and no patients on the placebo arm in the randomized RCC trial developed a pneumothorax. Bradycardia. In the randomized trial of Votrient for the treatment of RCC, bradycardia based on vital signs, less than 60 beats per minute, was observed in 19% of patients treated with Votrient and in 11% of patients on the placebo arm. Drug interactions. Co-administration with strong CYP3A4 inhibitors, such as ketoconazole, ritonavir, clarithromycin, increases concentrations of pazopanib and should be avoided, but if warranted, reduce the dose of Votrient to 400 mg. Avoid grapefruit and grapefruit juice. Concomitant use of strong CYP3A4 inducers, such as rifampin, should be avoided due to the potential to decrease concentrations of pazopanib. Votrient should not be used in patients who cannot avoid chronic use of CYP3A4 inducers. Concomitant treatment with strong inhibitors of P-glycoprotein or breast cancer-resistant protein should be avoided due to risk of increased exposure to pazopanib. CYP substrates. Concomitant use of Votrient with agents with narrow therapeutic windows that are metabolized by CYP3A4, CYP2D6, or CYP2C8 is not recommended. Co-administration may result in inhibition of the metabolism of these products and create the potential for serious adverse events. Concomitant use of Votrient and simvastatin increases the incidence of ALT elevations. If a patient develops ALT elevations, follow dosing guidelines for Votrient, consider alternatives to Votrient, or consider discontinuing simvastatin. There are insufficient data to assess the risk of concomitant administration of alternative statins and Votrient. Drugs that raise gastric pH. Avoid concomitant use of Votrient with drugs that raise gastric pH, such as esomeprazole, due to the potential to decrease concentrations of pazopanib. Consider short-acting antacids in place of proton pump inhibitors and H2 receptor antagonists. Separate antacids and pazopanib dosing by several hours. Adverse reactions in the randomized RCC trial. A dose interruption was required for 42% of the patients on Votrient. The Votrient dose was reduced for 36% of the patients. The most common adverse reactions, 20% or greater, for Votrient versus placebo were diarrhea, 52% versus 9%, hypertension, 40% versus 10%, hair color changes or depigmentation, 38% versus 3%, nausea 26% versus 9%, anorexia 22% versus 10%, and vomiting 21% versus 8%. Laboratory abnormalities occurring in greater than 10% of the patients, and more commonly 5% or more of the patients taking Votrient versus placebo, included increases in ALT, 53% versus 22%, AST, 53% versus 19%, glucose, 41% versus 33%, and total bilirubin, 36% versus 10%. Decreases in phosphorus, 34% versus 11%, sodium, 31% versus 24%, magnesium, 26% versus 14%, and glucose, 17% versus 3%. And leukopenia, 37% versus 6%, neutropenia, 34% versus 6%, thrombocytopenia, 32% versus 5%, and lymphocytopenia, 31% versus 24%. In a pooled analysis of Votrient clinical trials, East Asian patients had a higher frequency of neutropenia, thrombocytopenia, and Palmer-Plantar erythrodysesthesia syndrome than non-East Asian patients. Please see full prescribing information, including boxed warning and medication guide. This concludes our presentation. Thank you for your time.